Hello. Now I will discuss on Helicobacter pylori infection or Helicobacter pylori gastritis. H. pylori is a gram-negative S-shaped rod that produces urease, catalase, and oxidase, which play a role in the pathogenesis of peptic ulcer disease. The most likely mode of transmission of this bacteria is fecal-oral or oral-oral route. All children infected with H. pylori develop histologic chronic active gastritis, but are often asymptomatic. In children, H. pylori infection can manifest with abdominal pain or vomiting and less often refractory iron deficiency anemia or growth retardation. H. pylori can be associated so rarely with chronic autoimmune thrombocytopenia. Chronic colonization with H. pylori can predispose children to a significant increased risk of developing duodenal ulcer, gastric cancer such as adenocarcinoma, MALT or mucus-associated lymphoid tissue lymphomas. The relative risk of gastric carcinoma is 2.3 to 8.7 times greater in infected adults as compared to uninfected subjects. H. pylori is classified by WHO as a group 1 carcinogen. When we see signs and symptoms of H. pylori infection specifically, most people with H. pylori infection will never have any sign or symptoms. It's not clear why many people don't have symptoms, but few might have symptoms. When signs or symptoms do occur with H. pylori infection, they are typically related to gastritis or PUD. They might include epigastric pain that might be worsened when stomach is empty and that might improve with feeding. Nausea, loss of appetite, frequent burping, bloating, and unintentional weight loss. The diagnosis of H. pylori infection is made histologically by demonstrating the organism in the biopsy specimen. Urea breath test and the stool antigen test are labeled non-invasive methods of detecting H. pylori infection in patients who do not require endoscopic evaluation. So the diagnostic tests of H. pylori is classified as non-endoscopic and endoscopic. Most of the time we use non-endoscopic one such as stool antigen test and urea breath test. Nonetheless, for symptomatic children with suspected H. pylori infection, an initial upper endoscopy is recommended to evaluate and confirm H. pylori disease. The range of endoscopic findings in children with H. pylori infection varies from being grossly normal to the presence of non-specific gastritis with prominent rugal fortis, nodular region, or ulcers. Gastric biopsy should also be obtained from the body and antrum of the stomach, regardless of the endoscopic appearance. If H. pylori is identified, even in a child with no symptoms, eradication therapy should be offered. Successful H. pylori eradication is associated with cure of peptic ulcer disease and a very low risk of relapse. Therefore, monitoring the success of therapy is mandatory in these patients 4 weeks after stopping antibiotics and at least 2 weeks after stopping proton pump inhibitor therapy. Eradication can be tested with the urea breath test or stool antigen test. If there is an eradication failure, the patient should receive rescue therapy. When we came to eradication therapies for H. pylori infection, there are two modes of eradication therapy, which is called triple therapy and sequential therapy. Triple therapy is a combination therapy to eradicate H. pylori infection, which have three options. The first one is amoxicillin with clarithromycin and a proton pump inhibitor. The second is amoxicillin with metronidazole with proton pump inhibitor, and the third one is clarithromycin with metronidazole and the proton pump inhibitor. The other way of eradicating H. pylori is sequential therapy. The sequential treatment regimen is a 10-day treatment consisting of proton pump inhibitor and amoxicillin, both of them taken twice daily, administered for the first 5 days, followed by triple therapy consisting of proton pump inhibitor, clarithromycin, and metronidazole for the remaining 5 days. Let's see the dosage of drugs that is used for both triple therapy and sequential therapy. For all of them, proton pump is there. Proton pump inhibitor 1 mg per kg per dose twice a day for 1 month is recommended. Amoxicillin twice a day, clarithromycin twice a day, and metronidazole twice a day based on the kilogram of a child. Thank you for watching. If you have any question, please put it under the message or under the comment. I will reply. Thank you.